Okay, in our case, we had a guy presenting with paresthesia, and it was primarily on the left-hand side. Everything was on the left side of his body, and he also had tremors on his left. Now, the thing with paresthesia, so when we have a sensory deficit, you kind of want to isolate the lesion that's causing that. And the thing with paresthesia, there's a little bit of a disagreement on which tract it follows. Does it follow, for example, the spinothalamic, or the PCML? Upon looking into this personally, I think it can be both. However, most of the stuff I'm finding is for PCML. So I think the reason people are saying spinothalamic is because paresthesia is usually associated with sort of a pricking, burning, tingling sensation. We know that the receptors for the heat sensation run up spinothalamic, so that's heat, pain, stuff like that, where PCML is more of the fine sensory sensations. However, let me give you an example of two diseases. One of them would be Rabies dorsalis. So Rabies dorsalis. And one of the reasons it's called dorsalis is because it attacks the dorsal columns or the posterior columns. And one of its main symptoms, it presents with paresthesia. Another disease known as Laramite, and it's really Laramite sign. Laramite sign. This is a lesion in the dorsal column that you would get an electrical shock sensation. However, on dartmouth.edu, there's a page called Disorders of the Nervous System by Reeves and Swinson. Chapter 13, it describes how to evaluate numbness, and it lists the spinothalamic tract as one of the tracts you want to look for. And the main thing it says is that basically the take-home is whenever you have paresthesia, you want to check for the things that we know are in both spinothalamic and in PCML. So check for vibration, fine sensation, that kind of thing for PCML. And then check for temperature and painful and noxious stimuli for spinothalamic. And just a quick correction here, I just realized I've spelled paresthesia wrong. It's spelled with an E right here. So he also had, in his history of present illness, so his chief concern was the paresthesia on his left, and he also had tremors that were primarily on the left. And then he had irritation from his shirt collar. Irritation, I'm guessing, was probably an itch because he also had pruritic lesions where he had symptoms. And so we would say that this was probably spinothalamic, or I'll just put ST. And then you had the burning sensation, again probably spinothalamic. So while the paresthesia has a really good chance of being the PCML, or dorsal columns, a lot of the other sensations are pointing strongly towards spinothalamic. Another thing that would be pointed out, something common, if you're looking at the common stuff first, if you have something that's taking place on unilaterally and it's causing pruritic sensations, and you're having an irritation or a burning, and it's all on one side, probably the most common thing you would want to look for would be shingles, a reactivation of varicella. So that would be probably the most common diagnosis off the top. So we find out that, so this is the sort of the initial history. It was about 7 or 8 days ago, and then you come and then 3 days after that initial stuff happened, you come in and you see that he had chest pain that he went to the ER for, and they gave him they did creatine kinase and other and troponin, all the enzymes, and found there was no MI. So they gave him some medicine, sent him home. At that time he stopped drinking, and that's when he began to become tremulous. So at this point in time, you may be thinking delirium tremens. Delirium tremens is associated with alcohol withdrawal, and what you get is you can get confusion, disorientation, you can even hallucinate. And so anywhere between, so from Wikipedia, anywhere between 3 to 10 days after the last beer is where you're going to have the worst time with DTs, and it's usually treated with benzos. Now, it's important, I think, to point out, according to UpToDate, delirium tremens is defined by hallucinations, disorientation, tachycardia, hypertension, hyperthermia, and agitation, diaphoresis. I don't know if all of those are required in every case, but the fact that we don't have hallucinations, we don't have the hyperthermia and that kind of thing, it rules down delirium tremens. It doesn't rule it out, I guess, for me, but it does, I think, rule it down. I think it's also important to point out right now that delirium tremens in this case, the case is rabies, of course, that's the title of this, but it is a huge red herring. In fact, if you look up rabies on UpToDate, it says this. It says, although patients with delirium tremens can demonstrate agitation, experience hallucination, and have tremors, they do not exhibit hydrophobia or aerophobia. So that's in the section on differential diagnosis for rabies. So delirium tremens and rabies, it's going to present some of the initial symptoms in the exact same way. So now we have broad gait and balance problems, which is suggesting probably cerebellar. Now with dysphagia for liquids, this is known as hydrophobia, and this is basically pathognomic for rabies. At this point, not catching this is a huge deal. So there's different types of dysphagia. Typically a dysphagia is either for solids or solids and liquids. And if it's a dysphagia for solids, it usually is kind of a stricture in the esophagus or in the oral pharynx, whereas if it's solids and liquids, it usually is indicative of some type of muscle or motor problem. So it could be any of the motor nerves or the muscles that they innervate. However, here we have dysphagia for liquids only, so that's a huge deal. I've done extensive searching on UpToDate, on Google, on Access Med. I cannot find anywhere that lists dysphagia for liquids only and anything other than rabies. But I want to give you a disclaimer. There's nothing that says specifically that it's pathognomic, but if you Google hydrophobia, which is another way of describing this, that is the word that's typically termed as pathognomic for rabies. I think another important thing to get out of this is the tremors. So with tremors, you have different types of tremors. I'm not going to list them all, but the important ones would be resting tremors. Then you have intention tremors. And you have postural tremors. So those are probably the big important ones to remember as far as knowing what tremors are and how to classify them. So one thing you want to kind of keep in mind is, for example, with intention tremors, that's where if you tell a patient to touch a specific object in front of them and the tremor becomes more pronounced, that's an intention tremor. It typically represents something that's cerebellar. A postural tremor, on the other hand, is if you tell a person to hold a portion of their body against gravity. For example, if you hold your arm straight out in front of you, you're not trying to touch anything specific, you're just holding it there in one place, and that causes a tremor to become more pronounced, that would be a postural tremor. A postural tremors also tend to be cerebellar, but their causes are different. So everyone has a certain level of shakiness. Like if you got like a microscopic camera and aimed it at your hand, it would notice, you would see, like, it would look like huge movements, but that's healthy and everybody has that. It's called a physiologic tremor. However, it can become more pronounced with certain things such as medications, stimulants such as caffeine, anxiety, alcohol, for example, in our case. So we would want to evaluate if this is a postural tremor, if it's a resting tremor, an intention tremor, figure out what kind of tremulousness this guy has, or hyperthyroidism. So I'm just going to put hyper T. And then fevers can cause physiologic tremors to become more pronounced. So these are all physiologic tremors. There's also something called an essential tremor. Essential tremor is when it's not connected to anything and they really don't know what causes it. And these are also postural tremors. So subtypes of postural would be physiological and essential. A resting tremor is a tremor that is usually only going on while you're resting. And most of the time, the tremor will go away when you have intentional movement. But it's not always the case. It's just most of the time. For example, the most common cause of resting tremor is Parkinson's. And with Parkinson's, a small percentage of those people also have action tremors, which I'm not covering in this, but action tremors meaning that they could have tremors both resting and during movement. So now we covered tremors. Let's go back over. We also said that he's got slurred speech and he's talking off the wall. Now again, the slurred speech is also likely to be a cerebellar issue. But talking off the wall, we got to look at like a Wernicke and Broca and see how they mix together. And so with that, you would say you have your brain here, and here's the temporal lobe. And so right here you have your Broca's area. Over here you have your Wernicke's area. Well, typically, so Wernicke's area is like the language sensory or receptive area. So we receive language here. We break down the meaning, so you get meaning and stuff out of this area. And so if you have damage to this area, you're able to form the motor aspect. So motor of telling exactly how the words are to be expressed. So it tells your body exactly what to do to express what is being conveyed here. So this creates a thought or an idea into a language apparatus, and then it tells Broca's area to do something with it, and Broca's area says, okay, let me make the motor stuff work. And so with Wernicke's aphasia, you would be able to use normal grammar and syntax and speak normal words, but they wouldn't make any sense. And so it's known as a word salad. Oftentimes, even though it could be a sentence salad as well. The sentence could be completely coherent, but it wouldn't make sense in context of what's being talked about or what's going on. Now, on the other hand, if it was Broca's aphasia, it would be hard to form words at all. And so we can rule that down because he's saying words, but he's just talking off the wall. And so it could be anywhere from the Wernicke's area or in these fibers that transmit information to the Broca's area. So now we've got cerebellar, we've got posterior column, we've got these speech modules within the brain. So there seems to be a diffuse problem, but they're in specific areas. Okay, so let's go ahead and build up a differential diagnosis. Let's pretend like we have rabies on there because of the hydrophobia, but let's look at some other causes just to be thorough. One of the things, if you're looking at the chest pain, so we got chest pain, we've got the mental disturbances, and the paresthesia. These three things are common with porphyria. So the neuroporphyria, and I should go ahead and spell that right, porphyria. We also want to keep alcohol withdrawal on there. So we know the symptoms seem to have started before the alcohol withdrawal. We don't know, however, if those symptoms would have been acute had he, so there's complications here. Did he have something that would have just went away within a short time, or did the or was it a longer term thing? So we want to put alcohol withdrawal on the thing. We could treat those with benzos. Now, due to the chest pain and the striking amount of mental disturbances, we want to keep paraneoplastic. So paraneoplastic should be on there as well, and I'm thinking specifically like a lung cancer. You might want to check for that. And because of the chest pain and the high amount of neuro problems, you might also want to look for vascular problems such as TIAs and strokes. Then lastly, let's keep infection up. Now, I already mentioned syphilis with Rabies dorsalis. It usually takes several years, anywhere from 6 to 15 years, for tertiary syphilis and stuff like that to occur. We don't know that that's not the case, though, so we're just going to put infection. And under infection, I'm going to put meningitis, encephalitis, and then we'll put specifically like Rabies dorsalis. And just as another side note, paraneoplastic, he had a 22-pack year history of smoking, although it says he quit almost 30 years ago. In that amount of time, your risk factors for lung cancer due to smoking drop down significantly, almost to the base rate of the general population. But it's just something else to keep in mind. Then lastly, if we want to consider two types of things going on at the same time, we could say that there's sort of a central nervous problem, and that could be maybe alcohol combined with a peripheral nervous problem, and I'm thinking specifically like a spinal compression. And because it's only on the left side, you could do something called the Sperling's test. And so I'll just go ahead and talk about Sperling's test. We'll try to knock off each of these differentials one at a time. Sperling's test, what you have the patient do, so this is the patient's neck, and their head is leaning towards the side that is causing them problems. And then you apply your hands in an axial pressure pushing down. This is going to test for radiculopathy or a nerve root compression or a pressure. It's not very sensitive, but it's very, very specific. So getting a positive result would indicate that they have some type of nerve root impingement. So that would be how we may test for spinal type issues. Then we want to look at something. So let's talk about porphyria really quick. The signs for porphyria, you have the 5 Ps. So one of the long time things is purple P. So you would have purple P, and it would be either red or brown. But you can also get purple depending on the type of porphyria. You get painful abdomen, painful ab, polyneuropathy. Another one would be psychiatric. So we see a lot of these psychiatric symptoms, and then the last one would be precipitated, because it can be precipitated by other drugs, alcohol, or also starvation. Then coming back to our list, so imagine that we checked for porphyria. We also have the alcohol symptoms, and because of the porphyria could be precipitated by alcohol, that would be another thing that would rule that up. For the alcohol, we're going to treat with benzodiazepines, and when that doesn't get better, you can rule out the alcohol as the cause of these problems. Alright, so paraneoplastic syndrome, there's a mnemonic that says lots of bad stuff kills glia. So if you're looking for a central nervous system demyelinating demyelination type of device, these are all going to be cancers that cause a paraneoplastic syndrome that will attack the glial cells and cause demyelination. And this is going to be the lungs. L is lungs, B is breast, S is skin, K is kidney, and G is GI. So just remember, lots of bad stuff kills glia. And by the way, this comes out of first aid, so I give credit where credit's due. And also, speaking of credit, Murphy was the one that put me onto this. Thanks, Murph. So lung cancer would probably be the most likely out of all those cancers, but you could check for all of them. You could rule out paraneoplastic. Vascular, so you'd want to look for vascular things. They did do the heart enzymes, the cardiac enzymes, to check for MI, and it came up negative. And then looking at infections, you could do a spinal tap would be one of the first things you could do to check for infections, and do PCR and do all the ELISA or whatever type of test you wanted to do for the infections. However, we just find out that he was bitten by a bat. I should back up really quick, because under the alcohol and encephalitis, you can have like a hepatic encephalitis and stuff like that with alcohol, and it can cause cerebellar, and it can also cause thiamine deficiency. So I want to make sure I give everyone a complete differential. And so this is another reason why alcohol would be important, and I don't want to fail to mention that it's not just that you can treat with benzos and cross it off. You want to look at other causes of alcohol causing cerebral problems as well. And so I would check for thiamine, and I would also check for hepatomegaly and that kind of thing. Okay, now back to the bat. What can a bat bite cause? Of course, we know it can cause rabies, so it would give you a differential diagnosis. A strong differential diagnosis would include rabies, histoplasmosis, and maybe in other countries you would get things like Marburg and Ebola. So the top two, this is not likely in the U.S., But the top two, so histoplasmosis is caused by the fungus histoplasma capsulatum. And this is a fungus that typically will live in the soil, especially in the United States and the excuse me, it's in the Ohio Mississippi River Valley quite a but it can also be in other parts of the United States as well. Its portal of entry is typically going to be through the lungs, and so if you don't see some type of pneumonia, coughing, or difficulty breathing, bronchial problems, it's probably not going to be histoplasmosis. But that's the first thing you're going to want to look at is their lung involvement. And a lot of times it's going to just clear up on its own. If you are immunocompromised, however, you would require some type of antifungal treatment. So let's go ahead and rule out histo, and let's have this as our working diagnosis for the time being. So we're going to redo a physical exam. We're going to find that there's more cerebellar involvement, and basically that's the problems are spreading to cranial nerves. We go ahead and run some more tests. We see that he's got ketones in the urine. We've got opiates and benzos, which we gave him for his delirium tremens that we thought he might have. He also had an increased specific gravity. We'll come back to that. We did a venereal disease research lab, and just as a side note, that there's a few things that can throw that off. The mnemonic for it would be VDRL, viruses, drugs, rheumatoid arthritis, and rheumatic fever, and then lupus, as well as leprosy. A test that's a little bit more specific and stuff for that would be the FTA, which is the fluorescent treponemal antibody. So treponema pallidum is the test for is the syphilis microorganism. So fluorescent treponemal antibody is a little bit better of a test. So here, a real quick question: what caused the ketones in the urine? That's most likely going to be due to alcohol. So he's stopped drinking, but it hasn't been a long time yet. And alcohol, its effect on NADH and everything, it will cause an increased production, and it'll cause a shift toward ketone production. Now, we'll also do a lumbar puncture. The lumbar puncture, we find that most of it is looks good. Now, just as a reminder, the amount of glucose that you find in a normal lumbar puncture should be about 2/3 of what you find in the blood serum. So about 0.6 to 0.7 is the range, and that would be roughly 40 to 80 milligrams per deciliter is considered a normal range. We did see, however, some increased number of polymorphonuclear cells in there, 6% instead of 2%, and then we saw that the red blood cells were high. Of course, red blood cells are going to be high if you don't get a really clean LP. And the last thing we saw was that the opening pressure was at 21, and 20 is considered the cutoff. What we're going to see is that he begins to develop an increased intracranial pressure, which that's something that you're going to expect with rabies. And the last thing is we're going to run some specific tests for rabies, so you can check the saliva. The reason saliva, because once it starts being formed, it travels down into the salivary glands, and with the hydrophobia, you're not able to swallow. That increases the ability, like if you were to bite something, it would increase the number of viruses that get spread into the next thing. So it's sort of like an intelligent virus. We also do some skin biopsies and do some other work on it. Now, the first thing that's going to happen whenever the diagnosis of rabies is made, you're going to put on negative pressure room. Negative pressure is where you basically have air being sucked into the room and out through some other ventilation because you don't want any type of deadly virus like that spreading. It keeps the virus from going out of the room to somewhere else. Now, the problem with rabies is you have your brain here. Your brain doesn't, there's no changes. It doesn't die. It doesn't do anything crazy, but you stop making neurotransmitters. Just stop making neurotransmitters, and no one knows exactly why. So there's a that's a problem. So one of the treatments is tetrahydrobiopterin, which is BH4, and tetrahydrobiopterin is like a precursor and a cofactor for a lot of the neurotransmitters. So that can possibly be a treatment. You also tend to have increased vasospasms, and so the vasospasms, cerebral vasospasms specifically, so with cerebral vasospasms, you would want to treat it with a calcium channel blocker, but if you use just any calcium channel blocker, it can have an effect systemic wide. So you use a very specific calcium channel blocker, nimodipine, and nimodipine will act only on the cerebral vasculature. So what's the major treatment for this? There's a guy named Dr. Willoughby, and he saw through a research paper that whenever you cut the head out off of a person who had rabies and look at the brain, they did produce an immune response. They produced an immune response, but it seemed like they were just getting there too late. So if you're having a problem synthesizing neurotransmitters, the best way to give your brain extra time is to slow down the release of neurotransmitters. So we want to slow down the release, and we do that by inducing a coma, and then you give your body more time to mount the immune response. And with that in mind, with the Milwaukee Protocol is what this is called. Dr. Willoughby started this Milwaukee Protocol. If you haven't listened to it, Julie put a really cool episode from Radiolab about the very first time the Milwaukee Protocol was used. And it was just absolutely fascinating. I recommend everybody who hasn't seen it, watch it. So then it's a very sad thing. We induce the coma, we monitor EEG, we monitor the cerebral edema, and our patient still passes away. Very sad thing. But then you have to go ahead and do the histopathology and everything. Whenever you take a biopsy of the brain, what you should see with rabies, so evidence of rabies would include mononuclear infiltrates. You'd also expect to see perivascular cuffing, and that's, I'll just go ahead and write it, perivascular cuffing. And basically what that is you're forming a border around the blood vessels, and the border is typically like leukocytes, and it's seen in more than just this kind of infection. It's seen in a lot of infections, but you would expect to see it with rabies. Then you're going to expect what's called Negri bodies. Negri bodies is basically an intracellular or intracytoplasmic. So it's going to be inside the cytoplasm, so think of it, it's not inside the nucleus, it's inside of the cytoplasm. It's a Negri body, and it's going to be in the eosinophils. It's also going to be in the neurons, most notably the Purkinje. And so Purkinje cells of the cerebellum and the Amon's horn. And Amon's horn is basically the cells of the hippocampal formation. This is not very sensitive, but it is something you're going to look for. So it's found about 50% of the time with rabies. Okay, so that's going to wrap up everything for me. The last thing I want to say is that the Milwaukee Protocol is very controversial. It might actually be working, it might not. There's a lot of good arguments against using it, even if it is working. And so I encourage you to listen to the Radiolab episode about rabies and about the Milwaukee Protocol, and about Dr. Willoughby as well. And so that will explain a lot of the controversy around it. Also, when you have a patient pass away, it's never a good thing, but you do have to know the psychosocial aspect of breaking the bad news, and you can use the spikes mnemonic. And that's basically setting. You want a quiet, nice setting. The perception. You want to have information that would be helpful, knowledge. So you have to know exactly what the news is that you're sharing, and be knowledgeable enough to answer the questions. You need to have empathy. It's really important. And be able to summarize really well. Okay, I thought I was done, but I just realized that the fact that I haven't went through any of the pathophys of rabies itself. So first, the epidemiology. Epidemiology. This disease exists all over the world with very few exceptions. For example, Antarctica, no rabies. I don't know why. Then Japan, Sweden, Norway, Spain, Caribbean islands, and possibly Hawaii don't have rabies cases, but everywhere else in the world does. And there's an average of three deaths per year in the U.S. alone. Up until recently, whenever the Milwaukee Protocol was instituted, the death rate was 100% for any type of clinical case of rabies. So if you didn't catch it before it became a actual clinical case and get the treatments and prophylaxis for it, then you were going to die. However, that may not be completely true. Certain groups in South America have found to be resistant, at least in a little bit, to rabies, and so it may not. But as far as we know, in the western, northern western world, we are 100% death rate. There have been a few, I think 2 cases reported that didn't cause death where the Milwaukee Protocol was not used, and then other than that, there were about 30 people that have been treated with the Milwaukee Protocol and survived. So we know of at least 32 people that have survived rabies, and possibly a large group in South America that are naturally resistant. Rabies is a virus. It comes from Rabies virus. It contains a negative sense RNA and 5 proteins. It's a bullet-shaped virus. So that's not my best bullet, but that's a bullet-shaped virus. And the 5 proteins that it has is nucleoprotein, phosphoprotein, matrix protein, glycoprotein, and polymerase. So let's talk about how this virus works. So it's going to enter the muscle from a bite site and start to replicate. This is the phase where you can get a rabies vaccine and you can prevent yourself from getting clinical rabies. Then the glycoproteins that we mentioned, they will extend from the surface of the virus and be able to attach to various neuroreceptors. Then dynein will carry it up the axon of the neuron in retrograde fashion. It will move between 50 to 100 millimeters per day, and this is why if you have a bite on your foot, it's going to take a lot longer to get to your brain than, say, a bite on your shoulder, neck, or face. So once it does get into the brain, the main theory is that it prevents the synthesis of neurotransmitters. And by doing that, ultimately it's shutting down the brain. There are some other things that it does, like I mentioned already, that you get vasospasms, you get cerebral edema, and so all of these things work together to cause death, but mostly it's the inhibition of the neurotransmitters.